Good afternoon, students. We are happy to be back. For 2 days, our channel was occupied and hence there were no class. We are lucky that we are on time and we start the important topic for you today. I must make this disclaimer. The classes are done to benefit the students of Ukrainian University to facilitate preparation for examination and practice. It does not give any right, interest, or claim for registration, continuation, or certification by MUHS or its participating affiliated institution. We have discussed the diagnosis, clinical feature of diabetes, and now we discuss the management of diabetes, which was lecture 2. Alcoholic and other lecture we will continue to have in series. And since this is the topic which is asked more often in your universities, we felt that it should not be omitted at any cost, and that is why I am concentrating on that. More or less, we will be sending the PPTs to you in PDF by email. So even if you have got not to note down, you can understand the concepts and it is readily available for you to understand. What are the how to manage the diabetes? Diabetes has to be managed with the first and foremost is the patient education. He has to be taught what is the disease, how best he can be treated, and what are the challenges in the treatment. So these all has to be taught to the patient in the best possible way and in reasonably available interaction so that he is understanding his disease. And mostly, even if you are treating the best, but you are not explaining him well, the job is half done. Now comes the medical nutrition therapy and the exercise. If you understand the medical nutrition therapy and exercise can reduce the HbA1c by 2%, means it can reduce the sugar by 30 milligram deciliter only with this. On the top, hypoglycemic agents in type 2 diabetes, gestational diabetes mellitus have shown tremendous benefit to the population. And lastly is the most physiological, that is insulin. So we have to have that all four armamentarium should be understood, explored best, and then only the complete management of diabetes is possible. Patient evaluation, why it is important? If the patient is less than 40, thin build, ketosis prone, and there is negative family history, because family history is much lesser in the type 1 diabetes. So what you have to do? You have to do, if you know that GAD antibodies, which is specific at around 65%, ICA insulin centric antibodies, HLA linkages, and C peptide. C peptide is the residual of the broken insulin. So if C peptide is too low, it definitely tells you that it is type 1 diabetes. If it is, the answer is insulin and medical nutrition therapy and exercise, while oral hypoglycemic agents are out of question. In type 2 diabetes, that is around 90%, 5%, the age is mostly more than 50 years, they are obese, non-ketotic prone, and there is higher family history lineage if you analyze. So that is very, very important while patient evaluation. Secondly, you have to understand the cardiac risk assessment, because most of the catastrophe occurs with cardiac events, and that is why at the onset you should evaluate. So what are the risk factors, significant risk factors? There are numerous risk factors, but the significant risk factors are smoking, hypertension, hyperlipidemia, oral contraceptive pills. So these all has to be noted and modified so that the patients are benefited. Complication and associated diseases. If you know the person has got the disease of longer period of time, he has got autonomic dysfunction, neuropathy, he is prone to hypoglycemia, and that is why you prevent the tight control. If the patient has got very old patient, frail patient, patient with severe comorbidities such as malignancies, in those conditions, you are not much worried and you are more liberal with the glycemic targets. And associated diseases such as hypertension, kidney diseases, IHD, bronchial asthma, these all need to be collated and a complete plan should be made so that they are benefited. Laboratory evaluation for all the cases, including ECG, ophthalmic evaluation, they all must be done before the start of the therapy so that the effective therapy can be rendered. What are the therapeutic goals? The therapeutic goals are the patient should be symptom free. He should have optimal health and ideal body weight. Optimal health is achievable, ideal body weight is challenging because most of the patients don't adhere to as much the dietary discretion you suggest. But if possible, we must encourage them to go to ideal body weight. They should have good metabolic control, and metabolic control, how much I will explain in my next slide. And we have to prevent long-term complications, such as the ocular complication, the kidney complication, cardiovascular complication, and CVS. A lot of things can be has to be addressed. Lastly, prevent hypoglycemia. Hypoglycemia is a dangerous event. If it occurs, it kills the patient. Many of the people who have got this hypoglycemia and awareness and the pretext of diet control, what can happen? They can have hypoglycemia. Treat the life-threatening acute metabolic complication. There are metabolic complications such as the ketoacidosis or the HONC. What can happen? These very high level of sugars are associated with cerebral edema and they can have death in the problem. So targeted metabolic control is fasting sugar less than 20, ideally less than 110. What I want to bring it to your notice, this is the ADA guidelines and this is the AC guideline. Both of them are equally acceptable in the practice and public health. But as the patient are educated and they have got the access to internet, many of them will ask you that these patients should be having ideal control rather than the reasonable control. So I will request all the students to kindly print this slide and paste it in your book so that you remember it for your lifetime and it is achievable goal for your patient. So what is the role of education? Family part of the diabetic care program. Whenever you have got a patient, you cannot leave him counseling for himself or herself. You involve the spouses because they are mostly together and they are the one reminder, inherent reminder in the family. You can involve the children, grandchildren, and some of the people such as the custodian of the patient, such as jailer, the policeman, the head of the reform homes. You have to involve them. If we don't involve, you are doing the partial job. Nature of diabetes and chronic hazards has to be explained. There is a timeline I will show you in my slides, and the compliance to the therapy, diet, and self blood glucose monitoring has got the high impact in the care of diabetes. Hypoglycemia recognition, prevention, and treatment is very easy, but less done than stated. Personal hygiene, particularly the food care, and lifestyle modifications such as stopping of smoking is mandated. There is a huge evidence accumulated relaxation technique and yoga in prevention of the diabetes, acute as well as chronic complications. So that is why the role of education is huge. Coming to the medical nutrition therapy. So what are the aims? The aims is you have to take the patient to the desired weight. We have to avoid hypoglycemia and hyperglycemia. And simultaneously, you want to reduce the atherogenicity, and these are the main aims. How to achieve it? Diabetic diet is no longer used. What is now is the heart healthy food, same in as in non-diabetics. So how to make it simple, that it should be made simple, affordable within the patient resources which is locally available. It should be flexible, such as variety, likings, and all. You can't say the same food to a person from down south of India to the person of your Ukraine, because the style likings are all different. Or how to calculate? Calculate is the you have to calculate approximate requirement is the 20 kilocalorie per kg per day of ideal body weight, not the actual body weight. And heavy worker 35 to 40. Most of the patient you will find that is in the sedentary group and moderate workers. Don't calculate at 35 to 40 kilocalorie per kg body weight. Reducing the total calorie can reduce the obesity in the patients, and that is why you can have 10% weight loss in around 3 to 6 months if you are sincere enough to enforce the medical nutrition therapy. In dietary composition, particularly, you have to understand this is has to be calculated and explained to the patient. And what it is important is that you have to have carbohydrate 55% of the energy, fats less than 30% saturated fat, and total less than 30%. And cholesterol, very less amount should be there. And protein must be at least 1 gram per kg body weight, unless there is the nephropathy and patient is not on dialysis. So these are the things you have to remember. So what is I want to emphasize, the children, we have liberal with the calories because they have got the growth potential. In the moderate workers, I have given you the calorie calculation per day calorie of ideal body weight. That is the sedentary 20 kilocalorie per kg per day. You have to calculate, and moderate workers are the 30 kilocalorie per kg per weight. Many of the centers and apps are using 25 kilocalorie per kg per day of actual body weight, which is overstatement of the nutritional requirement. What type of carbohydrate? The carbohydrate should be used which have got the low glycemic index. Glycemic index means per time how much sugar is released. If it is low, it will keep releasing a small amount of sugar for a longer period of time. Which are the ones which are the low glycemic is the Maidas, that is the Maggi and all. You have understood like that. But the sweets, particularly honey, jaggery, so these are the ones you should avoid. You should promote whole grains. You should promote vegetables, fruits, pulses, and low cholesterol containing nuts, particularly almonds. There are no restrictions in taking salads, particularly kira, onion, radish, tomato, cabbage, and green. And non-caloric sweetener, aspartame, should be uh, promoted. The stevia is the herbal sweetener, so these can be promoted. The total sodium requirement per day should be less than 6 gram per day, and you can calculate easily with the total salt consumption in the family. Alcohol best avoided. If it is required, it has to be given very social and nominal alcohol consumption, even if in the old countries like yours. Fats, monosaturated fats, as should be given. Polyunsaturated fats should be very less used, and particularly the you have to plan fat content based on the available oil you get. You find that the olive oil, you find that the coconut oil, you can find the mustard oil, you can find the curdy oil. So these all have got the MUFA content. So what you have to understand, the MUFA content higher causes less atherogenicity and also known to reverse some atherogenic flux. So that is why there is the increased advertisement of certain types of oils for the heart safety. But we have to understand this is not the all. We have to understand the patient's convenience and availability of the oil, the amount of oil to be used, and then after how much is the to be distributed in the breakfast, lunch, dinner, and two snacks. So these all fat planning has to be done by the physician and doctors for their patient if they want good result. Now we come to the fact. You see, this is very important slide. I have adapted from the uh, book of medical nutrition in diabetes by American Diabetes Association. What you need, you see, soybean oil at the it has got the good amount of PUFA. Sunflower oil has good amount of polyunsaturated fat, and the major type which is available is the ones which are the freely available in the country. Olive oil also has got the good amount of polyunsaturated fat, but it is not so much available for India. The lifestyle modification, what is their weight loss, which is desired, has to be achieved with exercise. Only diet therapy or only drug therapy will not achieve the weight loss. So that is why exercise is must. That should be told to your patient in no uncertain terms, because it improves the insulin sensitivity, improves the physical and cardiovascular fitness, it gives the better glycemic control, it decreases the dyslipidemia, quality of life increases, quality of thinking increases, hypertension is reduced, and improved endothelial function. So these all benefits can be achieved by good exercise. Oral hypoglycemic agent and combination in that. When to start, it is, there are different school of thoughts. Whenever the earliest euglycemia we want to achieve. So there are certain places where diet and exercise need to fail to start the food. But in India, there are a hybrid population, affordable population, educated population. They are interested in diet, exercise, and drugs should come in simultaneously. And they are not wrong, and they are scientifically correct. So we cannot withhold the drugs that you first do diet and exercise, and then we start the treatment. That will be not the correct approach. So which one we have to start? We have to start. If it is very low, I will give you the targets, which are the, if it is less than 8, you can definitely try diet and exercise. 8 to 10 OHs must start, and more than 10 insulin OHs must start simultaneously. So that is the way we have to think about that. It is not that the 1 and 1. This is 1 and 1, which makes 11. Which OHA start? If the person is obese, metformin should be must. If he has got compelling indication to not start metformin, such as the kidney diseases, then you can think of others. And that is why metformin becomes the fulcrum of the treatment of diabetes. The common combination when above only single therapy fails, that is sulfonylureas plus metformin, sulfonylurea metformin plus glitazones, or if there is the postprandial hyperglycemia along with the sulfonylureas, metformin, glitazones, there is a role of acarbose, which is to be given to the patient. If the patient has got no adequate control in spite of drugs, oral hypoglycemic agent, insulin must be started early. Not insulin starting is may do harm to the patient. OHA induced hypoglycemia may be severe, recurrent, long. So that is why the patient who are on long-acting oral hypoglycemic agent, if there is a history of hypoglycemia, please be careful. And if there is the event, you admit him or her for at least 36 hours till the half of the drugs which they are taking is excreted. Now you understand there is the onset of the diabetes. This is the usual chart. It is taken from Kumar and Clark. What they are telling you that most of the people by 20 years and more they die. That is first incorrect. This is the old chart. What is there? In the moment diabetes occurs, there is the reasonable insulin reserve, and then after you have got diagnosis, you have to have microvascular complication assessment, oral hypoglycemic agents, or you have to get a combination of hypoglycemic agent, and more than 15 years, insulin has to be added, and then after stricter control or the liberal control based on the patient profile has to be ensured. Now coming to the agents, the sulfonylurea magletides, what they do? They tend to increase insulin secretion from the pancreas by sodium potassium pump inhibitor, and that is why it is available. The glucose output is reduced by metformin and thiazolidines. Peripheral uptake is again improved with the metformin. Insulin sensitivity is improved with thiazolidine, and glucose sidase inhibitor prevents the glucose absorption, and this way they prevent the postprandial hyperglycemia. So what you find there is it is defined on the basis of short acting, intermediate acting, and long acting. What is that? Tolbutamide is the favorite old timer drug which is available in the public healthcare system of many countries, including yours. I have gone through some of the treatment guidelines. We find gliclazide is it is available in India in good quantity, and particularly if the patient who has to be put on oral hypoglycemic agent with kidney complication, we tend to have. Glibenclamide again is the drug which is used. Glipizide is used very frequently in public health as well as in the domiciliary care, private practice. Chlorpropamide is long-acting drugs required to treat hyperglycemia for 36 hours and more. It is mostly it is condemned and they are hardly used. Glimepiride again has been promoted, and it is again oral agent which has got the good long-term control and lesser incidence of hypoglycemia. That is why it is preferred over the other agents. But head-to-head studies are very limited. The available agents you should select and give it to the patient based on his affordability and convenience. It should not be that you straight away go to the higher one and penalize the patient. What is there? The problem of side effect, they cause increased appetite, they increase hypoglycemia, and some of them are potentiated by salicylates, antifungals, and phenylbutazone. These are the ones particularly we should be careful. And if there is patient on any of them, the drug modification has to be done. Meglitinide, dipaglinide, and negletinide, they postprandial glucose control. And they, what is the problem? They cause hypoglycemia, they cause increased appetite, and subsequently causing to weight gain. But there are a specific subset of the patient who have having very severe postprandial hyperglycemia. These are the agent of choice. You have to give it to them in spite of having increased appetite and weight gain issues. And that is why it is mostly not so favored in private practice and public practice, but they have got their specific indications. Biguanides, very, very useful, available in all the centers, all the countries. It increases insulin sensitivity, peripheral uptake of glucose increase, decreased uptake from the gut, the decreased gluconeogenesis, saves the endothelium from the calcification, and there are a host of benefits. So metformin is the one which is used, and what is the goodness? It causes lot many benefits to the patient. The patient should not be deprived unless he is prevented from taking it. So that is the thing I want to emphasize. Side effects are dyspepsia, bloating, dysgeusia, there is heartburn, decreased appetite, and lactic acidosis, sometimes fatal and life-threatening, is also known, and particularly in the patient of diabetic kidney disease or kidney dysfunction. If the EGFR, estimated glomerular filtration rate, less than 30, you should not use metformin. If it is from 30 to 60, half doses, and above 60, it is reasonably safe, you can use it. But there is nothing liberal in modern medicine, you should be watchful. The indication is obese diabetics and most of the diabetics. Jolidons, they increase the insulin sensitivity by activating PPAR gamma receptors. And how does it do? They cause the insulin for acting longer and more effective, more glucose metabolism. Rosiglitazone and pioglitazone are the agents. They are freely available. They are reasonably cheap. But the issue of pioglitazone with water retention was overstated, and many countries have withdrawn it from the market. Even in India, it was withdrawn, but now it is reinstated as the alarm raised was not so substantiated in the scientific bodies. So that is why it is important. The patient who should not be given are the patient who are congestive cardiac failure, or the patient who have got the fluid retention occurring, such as in nephrotics and others. So these are the ways you have to stop. Alpha glucosidase inhibitor, acarbose, voglipose, miglitol, what they do? They prevent the sugar absorption. And that is why they are used in the cases where postprandial hyperglycemia is an issue. So what is the problem? The problem, it has to be taken with the food, and when taken with the food, it causes flatulence, bloating, and diarrhea. But it does not cause hypoglycemia, it does not cause any weight gain. The weight gain, even there are documented that the people in full doses, they lose weight. I don't say this is the correct way to lose weight, but the people who are moderately obese and having hyperglycemia, postprandial type, they should be given this drug. So this is a chart I have prepared, particularly the insulin level increases by all of them, except for by sulfonylurea and magnesium. Body weight is increased by the sulfonylurea, thiazolidines, and meglitinide. Most of them improve the lipid profile, particularly in the metformin and E-carbose. And hypoglycemia is noted more with the sulfonylurea and meglitinide. Most of them are not used. DPP-4 inhibitor again is used and it is freely available, cheap, and reasonably does not cause the hypoglycemia. Particularly, it is used in the Ramadan patients, and we have to be with that. But why I have not particularly made a slide? Because most of the cases it is not available in the country, and most of the examiners may not favor AP fluoride front. But in India, it is available and it is a good drug, and which should be added to metformin at the appropriate indication. So what you note here, the treating type 2 diabetes, non-obese weight maintenance diet, obese weight reducing diet, then a high lifestyle modification, alcohol cessation, smoking cessation, medical nutrition therapy, these all have to be ensured. After that, you have to add the metformin. Metformin should be liberally used up to the 2 grams per day or 2,500 milligrams per day. And then after, if it is not there, you add sulfonylurea. And if the sulfonylurea is also not working, then you gradually add, which is the issue you understand. If the issue is the postprandial hyperglycemia, then you have to use the acarbose. If it is the mild hyperglycemia, you can add the thiazolidines, you can add DPP-4 inhibitors, and is still not occurring, low dose basal insulin supplementation at night should start. And is still not a problem achieved, insulin is the answer. Now we come to the very important topic, annual review. Diabetic treatment should understand that the diet, exercise, weight change, glucose lowering, drugs should be done. What are the evaluation must for the patient who has come with diabetes? BMI, waist hip ratio, evaluation of injection sites, the examination of food must be done. For diabetic control, self-monitoring of glucose result, diaries, hyperglycemic symptoms, hypoglycemic events, HbA1c and LFT, and for people who are high risk job, particularly the flares and all, you have to do fructosamine. So these all have to be seen for the diabetes control. Diabetes control skills is that the secondary rules should be explained. The person who is having any illness, he should withdraw the insulin. Hypoglycemic treatment must be explained. Use of lozenges, honey, and the use of glucagon should be taught, and a few shots should be given to this patient. Insulin injection technique, again a very challenging thing to enforce all the patient, but if one-to-one taught by the physicians and the doctors, it does add to the value of the therapy. Macrovascular complication, IHD, peripheral vascular disease occurring. Most of the things are done with the simple clinical examination, standing, supine, and sitting BP can be done. CVS examination can be done. Heart rate variability can be checked. Respiratory system examination can be done. Lipid evaluation can be done, and ECG must be done. Eyes, the retinopathy, cataract should be looked for. Change of the glasses are very often. Loss of vision is also known. Visual acuity check at every annually, and fundoscopy every 6 monthly is mandated in many of the guidelines. In India also, these are mandated. We must do it in our country. Fundoscopy now it is 6 monthly. Nephropathy, you should look for the electrolyte, serum electrolyte, urea creatinine, microalbuminuria, and time urinary albumin creatinine ratio. So these all can be the neuropathy. If there is the altered sensation, if there is any, particularly in the feet, leg, and the distant part, weakness, autonomic dysfunction, such as erectile dysfunction, inability to start urine in time, these all can be checked and asked for in OPD practice. Postural fall of BP can be documented and it should be encouraged to do. Feet, pain, numbness, ulcer, footwear care, these all needs to be explained to the patient when they come for the review. Now come the insulin therapy. Which are the conditions in which the insulin is must? Insulin is most physiological and it has got the least of the complication. The provided it is used in by the safer hands, but to the needy patients. So what is that? Type 1 diabetes, yes. Pregnancy with diabetes or GDM, was initially it was the call of the day. Now the metformin has come up in a bigger way. Renal transplant, particularly the people are on prednisolone, and emergency situation, diabetic ketoacidosis or any other emergency sepsis, the insulin has to be. In type 2 diabetes, when there is OHA failure, and most of them require 5 to 8% patient every year with shift from the OHAs to the supplemental insulin, and some of them may switch to the insulin. So which insulin, which regimen, you have to decide. Acute condition, one and only one, that is the plain insulin. But if there is the chronic condition, intermediate acting NPH or mixed ARD should be given. There are newer insulin which are available, which can be given one and with the lesser hypoglycemic event. And that is why patient education. But the problem of the newer insulin with lower hypoglycemic events is the cost, and which is a very prohibitive factor in the chronic disease such as diabetes. Management of diabetes complication, diabetes, ketoacidosis, honk and coma, these are asked, and the chronic complication has to be dealt with, and age related coexisting illnesses, these all have to be understood and to be done. Particular complication will have a particular therapy. And that is why it is important to identify illness and then plan a therapy. Management prospect, what is the prospect? Why we are so concerned about the diabetes? The life of diabetics have increased tremendously. It has improved by average of 2 decades, means that previously diabetics used to die very early. Now they are living at least for the 30-35 years after diagnosis of diabetes. That is why complication prevention, the better insulin management, better delivery of the system such as insulin pump, insulin pen, better molecules are being done. Genetic therapy for the susceptible loci for diabetes mellitus, particularly the genetic related ones. And there is the huge pancreatic islet transplantation program is going, which is occurring along with the other organ system. So there are the huge chances of complete reversal of diabetes. Ongoing research are going on. At least every year, 2 to 3 molecules are introduced, which can save the patients. I have finished the common aspect. I have ensured that you have got the problems. I answer some of the questions. It is the kilocalorie per day. Omkar Zilla, your answer. Why are honey and jaggery contraindicated? They are the agents which have got high glycemic index. If you take it immediately, the sugar will rise. That is this. 8, 10, and 11 are the numbers I have talked about the HbA1c. So these are the ones which are there. Okay, sir, can you repeat when metformin is not used? The metformin is not used when the diabetic kidney disease is occurring, and when you are finding that the EGFR, estimated glucose glomerular filtration rate, is less than 30 ml per minute. So there is the Croft and Gault formula in your book, in which age, gender, weight, you calculate the EGFR. If it is less than 30 ml, you have to not to use metformin. Secondly, the people who had been lactic acidotic, they have got the metabolic defect. In those also, metformin should not be used. No, the people who have got the diabetes, type 1 diabetes, have to be given Ujjwal Kakadia for you. The people who are on insulin, particularly type 1 diabetes, they have to continue on the insulin. There is no two way. So insulin has to be given. Yes, bromocriptine has come in the way. There is lot of side effect. The benefit to use the bromocriptine is very less. In one large studies on 100 patients, they have given bromocriptine, and the reduction in HbA1c was only 0.5. So that is why bromocriptine is not so common. The newer insulin, Omkar Jila, your question, newer insulin, what is the problem? The newer insulins are basically tagged insulin, which have got the longer duration of action, and they are also causing less hypoglycemia. The problem with them is they are highly costly. The normal insulin, which is available, and the designer insulin, the cost is around 10 times. So all the patients who are on lifestyle disease, it is very, very difficult to ask them to go to the designer insulin or the newer insulin. Thank you. God bless you. My success is if you do well in life. I appreciate your thanks. I will send my presentation to all of you in today evening. You will get, and God bless you. Tomorrow classes, we again come to GDM rather than the alcoholic liver disease, alcoholic heart disease. Alcohol we will take next time. Thank you. God bless you all.